You are listening to the
World Extreme Medicine.
The World Extreme Medicine
podcast.
Today we're joined from Australia by Dr. Cara Sheppard. Cara is the Senior Medical Officer at Puntukurnu Aboriginal Medical Service, located in the remote Pilbara region of Western Australia. Welcome to the podcast, Cara.
Thank you very much for having me, Marcus. And I'd just like to start by saying that I'm currently on Noongar Budja and pay my respects to elders past, present and emerging.
It's great to have you. So PAMS, as we shall call the Puntukurnu Aboriginal Medical Service from now on, serves a population of approximately 1,500 people split into 5 separate settlements, with around 900 in Newman and smaller groups in more remote communities east of Newman. Now, speaking to Cara today feels somewhat familiar, as it was only about 6 months ago we were on Zoom and she was grilling me on health inequalities and my tolerance for working in 45-degree plus heat waves. Following on from this, in a fit of desperation clearly, Cara offered me a job working with PAMS starting next year, so I'm particularly excited about this conversation. When we were planning out a light structure for this chat, Cara, you referenced several epiphanies you'd had throughout your career, which I really liked. Could you tell us about your early part of your career and perhaps up to your first epiphany?
Thanks, Marcus. And I'm really looking forward to working with you once we get through some of the paperwork and other small roadblocks which are currently in the way. So my background is that I was born and raised in Perth, Western Australia, and I entered medicine through the undergraduate training program, which is the standard way, or was the standard way at the time that I started training. It's interesting now, actually, that Australia, or many of the medical schools here, are moving towards a more MD type program, a bit more similar to the States with postgraduate training. But I did an undergraduate course. I didn't have a particularly strong passion for medicine per se. I just sort of did the hardest course to get into. And then I sort of thought at the time, oh, look, I'll reconsider a year or two in, I'll kind of think, then I'll have a bit of a think. And then like 4 years in, I was like, oh, I forgot to reconsider. So I finished my medical degree at University of Western Australia, and I started doing my junior years. And at the time, certainly my area of interest was psychiatry and mental health. So I did, in Australia, it's very similar to the UK in terms of the thing, but it's slightly different names. So we have an intern year, and then most people go on to do an RMO year or a couple of RMO years, which is sort of similar to F1 and F2. So I did an intern year and RMO year. And then I went and worked as a service registrar in psychiatry. So I was working in the consultation liaison team at one of the big tertiary hospitals in Perth. That was the tertiary hospital which had the state trauma unit. And so that was where I spent quite a bit of my time working in mental health, was actually on the trauma unit. And that was quite an interesting area to work, because the trauma unit obviously has some people who are there for self-harm, but mostly we would get called in because the kind of people who end up on the state trauma unit are usually people who have been in high-speed motor vehicle accidents and things like that. And often there's drugs involved and alcohol involved, and just a lot of psychosocial issues, which ends up with them needing to see the consultation liaison psych team. And at that time, I applied to get into psychiatry training, but I didn't do very well in my interview. Apparently I used too much informal language, which is good that I work in the job I do now, because informal language is de rigueur in my current job. In fact, my patients wouldn't understand me if I didn't use informal language. And so I had another job lined up to work in mental health for the next year, but I sort of had to do a bit of a deep dive and go, oh, maybe I want to do something a bit different. Maybe I don't want to be working in mental health. And I hadn't turned off the part of my brain that was interested in physical health, in all aspects of health, really. So I went and worked for just as a medical officer on a standard psych ward for a bit. And then I came back and did the psych reg job in the emergency department for 6 months, which was extremely useful professionally, if distressing and stressful emotionally. And then I had applied to GP training, and I'd also applied to do a really useful 6 months of each job at the Women's Hospital and the Children's Hospital. And so I might give a little bit of background here about why that's super relevant for GPs in Australia. So this is actually, I think, similar to GPs in some countries as well as Australia, but perhaps not in the UK, is that GPs here in rural areas in particular often have additional skills. So for instance, it's not uncommon for GPs to do obstetrics or anaesthetics. And so there was a job lined up, which was essentially a resident medical officer working across the Children's and the Women's Hospital, 6 months of each, which was designed for GP trainees so that they could start the process of becoming, say, a GP obstetrician. And the pediatrics was really, really useful as well. So I did that. And then I got to the end of that year and I was still thinking about doing GP obstetrics, and I was sort of thinking maybe I'd go and do MSF because I knew that obstetrics was a really important skill if I wanted to do MSF. And I hadn't finished my logbook at all. So it was still half empty. So if I wanted to finish my GP obstetric training, which is what at the time was called the DRANSCOG, the diploma, and I think now is called procedural associate, I needed to go and continue doing some obstetric work. So I moved up to Geraldton, which is a regional town, about 30,000 people, 500 k's up the coast from Perth. As you'll discover through this whole discussion, that distances in WA are just different to distances anywhere else, unless you live in like the far north of Canada or maybe Siberia, but distances in WA are just magnified. Anyway, so I moved up to Geraldton and I did part-time GP training and part-time GP obstetrician work. And that was really, really useful professionally in terms of learning. It was a great opportunity for learning, but I discovered really quite quickly that working on labour ward was just not for me. I was sort of doing okay to start with, and then I had a complicated case, which all turned out fine in the end. But once the adrenaline high wore off, I just realised I had no business being on labour ward. I came to that realisation 6 months into a 12-month job, so I didn't really have any choice. I just had to keep working. But it was at that point I was like, oh, you know, maybe this isn't for me. So I just finished that off. And then I moved back to Perth. And so I was working in Metro Perth, and sort of during my time in Geraldton and before I came back to Perth, I'd had what I think would be my second epiphany. So the first one was the epiphany I had where I realized that psychiatry wasn't for me. And then the second epiphany was when I was up in Geraldton and I was permanently single and just social life non-existent. And I was like, oh, I'm almost 30. This is not where I want to be in my life at the moment. So I moved back to Perth and I was preparing for GP exams. And so I decided that I really need to sort out my social life as well. So that was sort of it was a good period of my life. It probably isn't recommended to be studying for your exams while trying to improve one's social life. But I passed the exams, so that's the important point. It didn't adversely affect my study that much. And I did meet my now husband. So all in all, it was fine. But I finished my GP training and I was working in Perth, working in metropolitan practice, just had a reasonably busy metro practice. But there was an itch somewhere that wasn't being scratched, that was just, I was a bit bored, wasn't really sure what I wanted to do. I still looked at MSF, but I had family commitments with my parents that meant that I really couldn't leave the country for sort of 6 months at a time, which is what would be needed to do MSF. And I'd also realised that I didn't really want to be doing procedural obstetrics, which would have been my main useful skill in an MSF environment. So I sort of decided, oh, I'll take 6 months off work. I'll see what I can do, do some locums. And that was when I saw a fly in, fly out job to work for PAMS in remote Aboriginal communities. And so I might just quickly explain fly in, fly out, because that's another WA special that won't mean much to anyone in the rest of the world. So fly in, fly out jobs are really common in WA because the size of the state and the sparseness of the population means that there's work that needs to be done in places where people don't really want to live. So it's really something mainly come out of the mining industry, where there are mines scattered right the way across WA, and they need to get workers to them, but they're actually not associated with towns. People don't really want to live there. So it's very common for people to fly in and do a set amount of time, which is called a swing, which is usually anywhere from a week to a couple of weeks, and then fly back to wherever their home base is. And so I saw a fly in, fly out GP job working for PAMS. And I really had no business going and doing that job. I didn't have really the requisite skills to do the job, but I was interested. And when I was interviewed, they seemed very keen, probably based on my enthusiasm more than my necessary skills. And I decided that I would go and try it out. So it was a 2-week block to start with. And I remember I was super nervous the first time I went. I was shaking. I was that nervous because once you signed on and then you sort of go, where am I going? I'm going out into the middle of nowhere. And I gave my partner a big hug, and I was just sort of saying to myself over and over again, it's just 2 weeks. It's just 2 weeks. And in typical kind of chaotic fashion, up until about 2 days before I arrived, I had no idea how I was getting from the airport to the community. I thought I was going to have to drive myself. I really didn't know what I was heading into. I'd never been to any of these communities. I'd never been even to any of these small country towns. I'd been to a lot of small country towns further south, but nowhere up in the Pilbara. And as I drove out, the nurse manager at the time, who is quite a good friend and has a lot of experience in remote areas, I was having a chat to him and I was like, oh, how often do you have to call the Royal Flying Doctors? And he said, oh, just like once a month. That was a white lie. but that was the story of how I ended up working in PAMS.
Fascinating, and can't wait to hear more shortly. But you mentioned a couple of times you've been tempted by MSF, and I know certainly it's something that's often gone through my head, and I'm sure lots of our listeners will either have thought about that for something later in their careers, or many of them done it already. What was it that tempted you by MSF, and perhaps why did you not go for that in the end?
So I think part of the reason to be tempted by MSF was the feeling of doing something useful. So I know working in metropolitan practice, sometimes you can feel like you're not achieving a lot. You're seeing mostly well people. It can become a bit monotonous, and it sort of feels like maybe that's not the biggest use of the skills that you've got. And then there's also the fact that clearly, even though labour ward was not for me, and I didn't have the the fortitude to survive on labour ward, I've obviously got a little bit of an adrenaline junkie in me. Otherwise, I wouldn't be doing the job I'm doing now. So clearly there was a little bit of that adrenaline junkie aspect to wanting to do MSF. However, the issue with going and doing things like MSF is both the skill set required, but also the commitment required in terms of being away from family, having to leave the country. If you've got animals or pets, if you've got elderly relatives that need to be looked after, all of those things make it a bit difficult. And, especially if you've got young family commitments. So I suppose where I work now, as you'll hear later on when I discuss some of the issues that we deal with, it is actually not dissimilar to MSF, but the advantage is I'm able to do it in the same state that I live in, and I get paid, and I can get back easily if I need to, and I don't need to be so far away. If I'd wanted to be really useful to MSF, I would have become an engineer, though. That is what I now obviously realise, or do logistics.
Absolutely, yeah. I think most of us during our careers as healthcare professionals have realised that, water engineer would have been a far more impactful career to go into. Well, it sounds like MSF's loss is PAM's gain, and perhaps if MSF go into the fly-in, fly-out business at some point, and you can do 2-week or 4-week swings, then perhaps that'll be a time then. But I mean, I'm really looking forward to hearing a bit more about PAMS and the services offered and more about your work. But just as a small aside, in the last few months, preparing for this role, and certainly, you know, feeling those nerves that Cara's described on her first swing, been doing a lot of reading about Aboriginal history and listening to other podcasts about Aboriginal medicine, and a fascinating book I read about the history of the Aboriginal population and Aboriginal communities, touched on some of the further back history. So to take us a long way back and really looking at, you know, over the years, over the last few decades, further more and more archaeological evidence for a continuous presence in Australia for about 60,000 years. And one of these books referenced another book called The Descent of Man, a fascinating read about how we've used genetics and specifically mitochondrial and Y chromosome DMA to look at how we have moved as a population around the world. And really the bit that was most fascinating was looking at where the original Aboriginal population had come from. And actually that was the first migration out of Africa, you know, over 60,000 years ago, when sea levels were slightly different, and so there was a lot more land. The very first migration out of Africa came up through the Middle East, tracking the coast, and tracked very quickly along the coast through Asia, through Southeast Asia, and then, you know, traveled down into Australia. And that was the first migration, and the subsequent waves of migration have populated the rest of the world. But I think, you know, an absolutely incredible thought that the Aboriginal population that Cara's looking after have got a continuous presence in Australia, continuously evolving culture for 60,000 years. And as Cara will come on to, some of the patients she looks after today will have first met, European settlers in Australia in the 60s. And prior to that, you know, their ancestors will have lived, you know, a culture almost unbroken for over 60,000 years. So I won't bore us anymore with tales of archaeology and things like that, as I'm certainly not an archaeologist. But Cara, it'd be fascinating to hear more about, you know, PAMS, the services offered, and more about the communities that you're actually looking after.
Yeah. So the history of Aboriginal people in the Western Desert is a very, very long history. And I suppose I should start out by pointing out that I'm a white person, or as I call myself and as my patients call me, a white fella. And I'm not an anthropologist, and I don't claim to have any expertise in this area. And I'm also approaching a lot of these things from a scientific and Western viewpoint, which is quite different to the perspective that the local people would have on lots of these different issues. But I can tell you a little bit about the people that I work with specifically, more about the Matu than the Nyabali people. I have heard a bit more about their history perhaps. But the Matu and Nyabali people were some of the last Aboriginal people to come into contact with white settlers. So they have lived in the Western Desert for tens of thousands of years. Matu actually isn't an original language name. Matu is an amalgamation of a number of other languages that sort of came together more recently. So prior to the arrival of white people, actually, the Matu language as it now exists wasn't a language. It would have been made up of smaller dialects. And that is one of the really fascinating things, is that a lot of these languages would have maybe a few thousand speakers at most, because they were individual languages for small groups of people who were living in the desert, living a nomadic life. And so they would be covering vast distances, and their languages would evolve to be slightly different to each other. Settlement in the Western Desert was very late. I should probably mention a little bit about the climate, because that's why the settlement was so late. So the Western Desert is a very arid environment. Obviously, it's called a desert. It's affected by 2 seasons. So you have a hot and wet season, which is what we would call summer. And then there's a dry, slightly less hot season, some may call it cold, season, which we would call winter. And there isn't really like a spring and an autumn season. That doesn't really exist. There's just the wet season and the dry season. But there's not a lot of permanent standing water in the dry season. And the desert itself is very sparsely vegetated. So it wasn't really suitable for agriculture. And if you read the stories of the early white people who went out into the desert, look, not many of them survived. Quite a lot of them would have got lost, died of starvation, died of thirst, etc. So it wasn't an area that was known to white presence early in the settlement. However, in the early 1900s, the Kimberley, so your listeners would not really know the regions of Western Australia, but essentially Western Australia is a very, very large state. And so the Kimberley is the very top part of the state. In the Kimberley, they were farming cattle up in the early 1900s. So they had big stations there. So when I say big stations, like I drive through 2 stations on my way to work, they're each probably about 50 kilometres wide. So that's sort of the size we're talking about, huge, big areas of land. But they were able to let cattle roam in the native vegetation. They were surviving, but they needed to get them down to the southern markets, which is where all the people were and where the slaughterhouses were and so forth. And so that led to the creation of the canning stock route. So the canning stock route has not a very good history. People can read about its history, but essentially it was formed by explorers who were looking to bring cattle down south. They needed to make wells along the route. And so one of the communities that I work in now, Kunawarigi, is also known as Well 33 on the stock route. And in order to find the water, they needed to use the local Aboriginal people's knowledge, because they had obviously intimate knowledge of where water sources were and the very few places where there was permanent standing water. But some of the techniques that they used were quite brutal. And so it is thought that, for instance, they captured Aboriginal people and fed them salt and then followed them to the water when they got thirsty. So things like that. So it's quite a brutal history to the canning stock route. But that was sort of part of the first coming of white people into that region. And that was the origin of the Kunawarigi settlement, is that was Well 33 on the canning stock route. Another community that I go to, Jigalong, had a slightly different start. So it was settled by white people, again in the early 1900s. That was the building of the rabbit-proof fence. So people from other countries might think rabbits are cute little fluffy things that hop around. But actually in Australia, rabbits are an enormous problem. They're a huge pest. Someone with less than ideal judgment in Victoria released some rabbits because they wanted to hunt them. And they presumably also wanted the area to look a bit more like their home where there had been rabbits. And rabbits actually really like the Australian environment, and there was no other animal like a rabbit. And they absolutely destroy the landscape. They eat out the vegetation. They cause a lot of harm. And so by the early 1900s, the effect of rabbits was known. And Western Australia was rabbit free. So they attempted to build the longest vermin fence in history. I believe it was 1,800 kilometres long, to keep the rabbits out. And so Jigalong was one of the locations that they were building the rabbit-proof fence. And so that was the initial settlement. And then once the fence had been built, it was handed over to missionaries. So when white people started going out into the desert, they were followed by missionaries who obviously were trying to recruit and convert people. And initially, a lot of the people coming out of the desert actually did come out of the desert of their own accord, because living in the desert was hard. It was a nomadic way of life. You had to hunt your food. You had to harvest your food yourself. For instance, damper, which is now considered, I suppose, a little bit of a traditional Aboriginal food, is made with white flour, which was not a traditional Aboriginal food. But if they did want to make essentially similar to damper, they would have to go out and harvest the seeds, shake them out, grist them by hand, grind them by hand with a stone, and then make them into a dough and then cook them, which was a lot of effort. And the missionaries brought with them white flour, white sugar, and tea, and then also tobacco. And so those things were highly sought after, and people from out in the desert actually did come into the missions, sometimes voluntarily, because they had those foodstuffs. However, the missions themselves now have also got quite a traumatic history. The missions were involved in separating a lot of children from their parents. People may or may not have heard of the stolen generation, where Aboriginal children were taken away from their parents to assimilate into white society, and the missions were a big part of that. So those histories are very traumatic, and the missions now have, I guess, a reputation for brutality. And that was up until quite recently. So the mission handed it back at Jigalong, handed the location back to community control in 1974. Up until as late as the late 1960s, Aboriginal children were still being taken away from their parents. So we're talking about really quite recent history. So that was how Jigalong started. A couple of the other communities that I go to were founded in the 1980s. So they were part of the homecoming movement. So Punmu and Bangor. And they are communities that were founded that involve people coming back to country because they realised that the towns were not good places for them. So they would come back out to country, form dry communities away from the grog, and where they could reconnect with their cultural roots, reconnect with the desert, with the land, and try and live a more traditional life, but I guess a more peaceful life, away from sort of a lot of the elements of, I guess, whitefella society that caused a lot of problems. And it's worth noting as well that, like, some of my patients first met white people in the 1960s and 70s. I have patients who only speak desert languages. And even as recently as the 1980s, there was a group of people not far from Kirakara, which is a community that's not that far, probably a couple of 100 kilometres away from Coonawarrigi. There was a group of nomads who were still living their traditional life in the desert and had not had contact with white people, who had their first contact in the 1980s. So everything is very, very new with the contact between people in the Western Desert and white people.
Fascinating, amazing history. And how did PAMS come into that? So, really interesting to hear how some of these communities came to be, and especially that homecoming movement, and actually seeing Aboriginal people moving back to country. You may want to give us a little idea of what country means to Aboriginal people. So I know it's a slightly more nuanced understanding than we might think of. And then how did PAMS come to look after its patients?
So I'm probably not really qualified to talk about what country means, but it's a very deep spiritual connection with the land, with the animals, with the water. It's essentially, you could think of it as a religious connection, and it would be to various different areas, people who come now from more mixed backgrounds. So they might come from a few different cultural backgrounds in terms of language groups. They will feel a connection to the areas that have traditionally been the homelands of that language group. And certainly getting people back on country seems to be associated with better health outcomes. So nowadays, there are organisations who try and get teenagers, in particular kids, back out on country, because they seem to cope better once they get away from the towns and get back out and connect with their spiritual roots. In terms of the origins of PAMS, so PAMS was formed in the early 1990s, and it's an example of what's called a community-controlled health organisation. So in terms of how health services run in Australia, so essentially general practice and primary care is run through a universal insurance scheme called Medicare. Most general practices run as private organisations or individual practitioners, or a practice owned by a practitioner. So the difference with a community-controlled health organisation is that it's actually controlled by the community. It's usually answers to a board. So there'll be a board of directors, and that will be made up of members of the community. It'll be elected by the community, actually. So they'll have an AGM every year and elect their board members. And then those board members will be responsible for the delivery of the health service, then through people that are employed by the health service. And the funding for it is slightly different. So Medicare money makes a big component of the funding, but there's also usually grant funding. And that's because the complexity of the cases that are seen is a lot more than you would expect in a regular general practice. And the way that Medicare is funded, which is funded based on time spent with each consult, doesn't really reflect the amount of administrative work involved with really complex case management, and also just doesn't really work if you have a low throughput. So generally speaking, a lot of the community-controlled health services receive additional grant money to keep themselves running. They also provide a variety of other services. So depending on the individual organisation, and that's the thing about community-controlled health organisations, is that they are driven by the needs of the community, and they are organised to meet specific needs. They might have environmental health, they might have social emotional well-being, they might have housing, some of them provide aged care. Now that we have the National Disability Insurance Scheme, a lot of them provide NDIS services as well. So a lot of additional sort of allied health and other services that wouldn't be part of a usual GP practice. And with PAMS, it covers 5 communities now, but when I first started working for them, it was only 4. So it traditionally just covered the remote communities. So those are the ones out in the actual Western Desert. But in 2020, we opened up a new practice in Newman, which is a bigger town. So it's a more established town rather than being a community. And so now we have a couple of GPs working there, and then we provide services to all of the other communities.
Fascinating. And what kind of level of services are on offer? So you've talked, obviously you're a GP and talked about primary care. I suspect, I know in Newman, it's run as a standard GP practice with a small, rural regional emergency department down the road. But in the more remote communities, so the 4 that are east of Newman, the smaller desert communities, what's the kind of ceiling of care? What can PAMS offer to its patients in those locations?
Yeah, so the ceiling of care is determined really by the people that are there and the equipment that is there. And in actual fact, that is part of the reason why I'm able to do the work that I do, because of the ceiling of care, because it means that in some ways I find it quite freeing that you don't have to do complex procedures, you don't have to manage complex equipment. because you don't have complex equipment. So what we provide is we try to have a doctor on the ground most of the time in Jigalong, which is the biggest community. That's about 300 people. We have 3 nurses there. We have emergency telehealth. So we have a video conferencing system that we can access an emergency physician for advice and management and so forth, and to help organise an RFDS transfer. We have an iStat machine. So we can do essentially like a blood gas, Chem 4, Chem 8. We can do point of care troponin. We can do point of care HbA1c, point of care syphilis testing, point of care chlamydia and gono, HemaQ. And then we have basic resuscitation equipment. So we have the equipment for managing, say, an airway, but we don't have a ventilator. So if someone required airway support, then, and you intubated them, for instance, you would then have to manually bag them until the roll flying doctors arrived, which might be a while. In the other communities, we have nurses there all of the time, remote area nurses, but the doctor only comes 1 day in 14. So the distances are quite considerable. So getting from Jigalong to Newman, or in the other direction, it's about 160 k's, of which about 50 is paved, and the other 110 is dirt the whole way. To get out to the other communities a bit further out, I go by charter plane. So I go in a six-person charter plane, and it takes me about 45 minutes to get to the first community, another half an hour, then another sort of half an hour to get to the last one. And so we provide a doctor 1 day in 14. We have visiting services as well. So we take a paediatrician out a couple of times a year. We take a diabetes educator, a podiatrist, optometrist, audiologist. We also have a visiting ENT surgeon who goes out and provides a service. And apart from that, those are the main services, really. If we need radiology, there's no X-ray machines. So it's either a trip by road, or if you're sick enough to need the RFDS, obviously you get the RFDS. If you're not sick enough, it's a trip by road. So from the furthest community out, Puntukurnu, that would be about a 700-800 k drive to get a plain X-ray. CT scan, likewise, is a similar thing. Newman town has got plain X-ray and ultrasound. So from Jigalong, it's just 160 k's, but CT, the nearest one is Headland, so that's 500 k's. And then blood tests. So the mail plane comes once a week, and so that's how the bloods get out. So if you take a blood sample and you take it too many days before the mail plane, the full blood count's cooked by the time it gets to the lab. So we get a lot of very interesting, mild neutrophilias, which I think are just basically because the sample's cooked. And so, and sometimes the lab calls it and says, no, that sample was no good. We're not processing that. So yeah, so blood samples go out once a week on the mail plane. And they actually, even Newman doesn't have a lab to process blood. Even Newman ED doesn't have a lab. So they have in effect, similar to what we have in Jigalongs. They have iStat machine, point of care troponin, and point of care CRP. They do have plain X-ray. And so everything just gets taken into Newman and then taken to Perth. And because the mail plane goes on Thursdays, the bloods often don't get processed until Monday the next week, by the time they've made it all the way to Perth.
Geez, a slightly different approach to investigating things then, slightly more delayed, a little bit of patience.
You need to learn to work without the blood tests. You have to take an educated guess at what the blood test is going to show you.
Excellent, yes. Brilliant. Well, so that really paints a picture of kind of what you're flying into, I suppose, how you're getting to work, flying, which I can't say there's many GPs which are flying to work every few weeks. So really paint a picture of where you're flying into and what you've got on offer to help, as you say, inform your decisions, or perhaps not inform your decisions. What was it like first going? So you mentioned that the nerves of your first swing. What was that kind of first trip like? What were the adjustments going from metropolitan Perth out to Jigalong and remote desert communities?
So it definitely was eye-opening. No question about that. So it's an hour and 45-minute flight to get to Newman. So you do an hour and 45-minute flight, and then you previously, not so much now I bring my food with me, but I used to go into a grocery shop. So you go into Woolies, which is the local supermarket, pick up your groceries, and then hit the road. And then it's about a 2-hour drive to get out to Jigalong. So the first time I did it, the nurse that was driving with me and we talked the whole way in. I presume he was sort of sizing me up actually to see, you know, is this person actually going to survive out here? And it can feel like there's absolutely no one else on the road. Now that I've done the trip many, many times, I know that actually if you're driving out there, you'll probably pass about 4 cars on the trip. So it's very unlikely you're going to break down and no one's going to come past to help you out. But it can feel like that you're literally in the middle of nowhere. And the 110 Ks on the dirt is a long way. It goes through 2 cattle stations, Balfour Downs and Ethel Creek. And there's no signs of humans apart from the dead car bodies on the side of the road. There's quite a lot of dead car bodies. And so you just drive and drive and drive on this dirt road. And there's big like termite mounds on either side and just red dirt as far as the eye can see. So you really do feel like you've come to a completely different place. And then, so there's the distance, which is just, you know, which is just huge. And then there's the clinical aspect. So as I said before, the lack of equipment can be quite freeing because the reality is that I don't need to know how to put a central line in. I don't have a central line kit. So that's not a skill that I need to have. But it can, if you think about it too much, you can get overwhelmed with anxiety. And in fact, I think that's why it can be sometimes quite hard to recruit to the positions out there, because a lot of people look at that and go, well, I can't do that. I can't be by myself. I can't work without my usual supports, without my radiology, hot and cold running radiology and labs, and hot and cold emergency department. And I think that when I first went out, I was quite gung-ho, but really, really nervous. And every now and then I still get overwhelmed by anxiety, actually, if I think about it too hard. The best way is to not think about it. But also over time, I've sort of developed a bit of a sort of realistic fatalism. So the reality is that if something really bad happens out in the middle of nowhere, the chances of you getting someone back from a cardiac arrest, for instance, are just infinitesimally small. I mean, the success rates for out-of-hospital cardiac arrest, for instance, even happening in cities, are not great. When you're waiting for the roll flying doctors to come for 3 hours, it's very unlikely that you're going to have a good outcome. And so although we absolutely have to follow the protocols and we have to do the best that we can, it is also helpful to just realize that the distances mean that sometimes bad things are going to happen and you may not be able to do anything about it. So that was a bit of a realization that that I had to come to, that is quite hard, but helps in terms of being able to go out and do the work, to recognize that these are the limits of what you can do, that the services that we're providing are the best that we can, and that a doctor is better than no doctor. And within the limits of the physical equipment that is available on site, we can do quite a lot, but we cannot work miracles.
Yeah, so I think that's something I suspect lots of our listeners will have come across working in various places, is that exactly we're always doing the best we can, but in certain places when you don't have that, as you say, hot and cold ED department around the corner, certain things can't be done. And I suspect that those first few rotations, or perhaps even still, I would imagine many years later, there must be a significant cultural aspect to the job, and things that make the job, I imagine, fascinating and interesting, but also really challenging. What are some of the biggest cultural differences and challenges you've found working in these remote communities?
So there are lots of different elements to the cultural differences or the cultural aspect to working in these communities. And you can sort of break them down into different parts, but they're all sort of intermingled. Probably the first and easiest one to talk about would be language barrier. So some of my patients speak no English at all. And for many, or if not all of my patients, it will be a second language or maybe a third language. Health literacy is quite poor. And general literacy also can be quite poor. So trying to explain things and trying to be safe can be really difficult. And so those communication barriers actually can lead to serious medication errors, but mostly I find the communication barriers lead more to issues with people not understanding the disease process that you're trying to inform them about, not understanding directions around diet and lifestyle factors, and not understanding instructions around medications, things like that. So there's that sort of general communication issue, which I think happens with anyone working in a situation where two people that are working, where a patient and a provider are speaking a different language to start with. And then there are some of the other cultural aspects that are a little bit unique. So for instance, out in the Western Desert, traditional payback still occurs. Traditional payback occurs when someone has died or in some other way come to harm, but usually died, and people are held responsible for it. And the reasons why they might be held responsible are often rooted in deeply spiritual beliefs, beliefs around sort of witchcraft, or people having been cursed, people having been affected by, say, evil spirits, or someone having put a curse on another person and that having caused them to pass away, or just someone being in the vicinity of the deceased person in the lead up to their death. And so we definitely do see payback happen. We also see a lot of general belief in spirits and spirituality, and that can be quite challenging, especially in mental health. So certainly if someone comes and says that they've been affected by a bad spirit, or they believe that they've been sung, or another belief like that, there's always that question in every mental health consult, I suppose, around, is this a culturally acceptable belief and therefore is not a mental health problem, or is this not a culturally acceptable belief, or is it perhaps a culturally acceptable belief, but it's causing them a fundamental problem with living their life, so it's affecting them in a negative way. So I suppose like an example might be that someone might think that God is talking to them, but it's negatively affecting their life, and we call that a mental health problem, and we treat them, because even though believing in God and God talking to you might be culturally acceptable, in this instance it's negatively affecting their life. Well, it's the same issue that we have to deal with in trying to figure out whether something is a cultural belief and is accepted within the community, or is this something that's negatively affecting them. And we also run into a lot of issues around communication where there is mistrust. So obviously with the history of colonization and the service providers mostly being, or almost all in our circumstances being, non-Aboriginal people, there's not a starting point of a huge amount of trust. And I've particularly seen the mistrust coming to a bit of a head for diabetics, because diabetes is a really tricky disease to understand. You need to understand what sugar is. You need to understand how you can have sugar in your blood. You need to understand that that can cause you harm. These are complicated ideas for anyone to understand. And for people who haven't done perhaps any scientific or medical education or basic human biology, it can be really tough to put all those ideas together. And the other thing about diabetes is you would be amazed at how abnormal someone's labs can be and that person to have no symptoms whatsoever. So the symptoms are often really subtle, or they just don't experience any symptoms at all that they have noticed. And so I've found it really challenging to get across to people that they have diabetes, that they need to do something about it. Often there might be a lack of belief that they have the disease at all, or there might be a lack of trust in white man medicine. So people aren't willing to take the medications. And then some people might sort of think that they can manage it with, say, bush medicine. And I don't have anything against bush medicine. I encourage people to use bush medicine, but generally speaking, it isn't, in my experience, sufficient to manage really poorly controlled diabetes. And then there are also issues around people's understanding of correlation and causation, which is not unique to working with Aboriginal people, but I suppose is something you'd see with any group of people where they haven't had a huge amount of scientific education. So as an example, most of my patients who have diabetes have got a relative who's ended up on dialysis. Kidney disease is really, really common. Lots of people end up on dialysis. So most of them had a relative on dialysis. And it's quite common as well for someone to end up on dialysis and start insulin at about the same time, because everything just sort of comes to a head. Their diabetes and their kidneys, it all comes to a head. They become more closely engaged with health services at that time, and they get started on insulin. And so a really common fear that I've heard from people is that they think that insulin causes dialysis. Or a similar sort of theme of insulin causes death. They've had a relative who had out of control diabetes, started on insulin, and then dropped dead. And from their understanding, they think the insulin caused the death. And of course, from my understanding as a clinician and as a scientist, I understand that the insulin was there to try and prevent death, but they had reached a point in their disease process where all of these things had come to a head and caused their kidneys to fail, caused them to die of a heart attack or whatever. But you can see how logically people might come to that understanding. So those are some of the cultural issues. There's also another challenge that we see around prioritization. So for most people that I work with, cultural priorities are the number one thing, or cultural obligations, especially around funeral attendance. That's a massive cultural obligation that people need to go to funerals. And so this often takes priority over physical health issues that might be affecting the individual, or any sort of individual issue, but we see it in health. And so that intersect between their personal lived experience and priorities and the Western health system, which runs on appointments and waiting lists, often means people don't get maybe the service that they need. So I get a lot of patients who I've referred multiple times for the same problem to the same specialty, and they've missed so many appointments that they've been struck off. And then I refer them again and they miss lots of appointments and they get struck off. And it's because what's important for them is not what's important for me. So I am putting priority on getting them to see this specialist. They have this physical health problem I'm trying to get them in to see someone about. And it's not that that isn't an important problem for them, but they have other more important things going on in their life at that time. And so they don't make it to those appointments. And it doesn't help either that because of poverty and lots of other reasons, and also just cultural obligations to be at different places at different times, and a very mobile population, a lot of people don't have a fixed residential address. A lot of people don't have a fixed phone number. So when they get given an appointment, frequently they don't know about it. And if we as the service providers don't know about the appointment either, which sometimes for sort of privacy reasons, the appointment details get sent directly to the patient rather than to the service providers, we can't help them to get to their appointment, and then they miss all their appointments.
Fascinating. I mean, so many things to consider there alongside the medicine, which, you know, must make the job so interesting but challenging, like you say. A couple of questions. You mentioned payback and some of those kind of beliefs around, you know, when someone has died. Are those generally directed towards, you know, other community members and family in terms of sort of curses and witchcraft, or sometimes are you as the doctors and nurses looking after them sort of caught up in that that payback process of being around someone, looking after someone, you know, when they died?
Fortunately, in my experience, it is confined within the community and not involving service providers. There are some other cultural elements that can affect service providers. For instance, if a patient dies in a clinic, then that building will probably not be acceptable for people to enter for a period of time afterwards. Usually there might need to be a smoking ceremony to cleanse the building afterwards. So if someone dies in a clinic, that can cause issues. But generally speaking, payback is not practiced on outside people or people who are not acknowledged to be part of the community, which is a good thing for service providers, because obviously we will be intimately involved in people when they're very unwell. And so the risk of us being thought to have caused a death could be quite high.
Yeah, that's understandable. And in terms of your cultural understanding, you know, clearly your cultural understanding is quite sophisticated, although, as you say, you know, nowhere near the depth and understanding of the Aboriginal communities themselves. How have you learnt that? Is that something you've picked up from the community? Are the community open in educating you? Are there other resources, you know, available to healthcare professionals like yourself in Australia to help develop that understanding? How do you go from, I suppose, looking ahead for someone like myself, how do I go from a zero understanding to an understanding that allows one to practice in a culturally appropriate way?
So there isn't one answer to that question. A lot of what I've picked up has been through learning on the ground. We as an organisation do cultural awareness training. So all of our staff members are meant to do cultural awareness training, and certainly the history around the canning stock route and things like that, those were things I wasn't really fully aware of until I did cultural awareness training. But learning about what happens in each individual community, because every community is different, is something that you really learn on the ground, and from other service providers as well, and from talking to community members. And it is one of those things where there is obviously the great potential to make missteps. Fortunately, although there sometimes is a lack of trust in outside service providers, overall, for the most part, the understanding is that we are trying to help and trying to provide a good service. And so minor cultural missteps would usually be able to be worked out.
That's reassuring, because I think I probably make a few minor cultural missteps in the UK, despite being a world away. So you mentioned high rates of diabetes and renal disease, you know, lots of patients on dialysis or needing dialysis at some point. What other kind of pathology are you seeing, in particular, those kind of things which would really different from kind of metropolitan or sort of urban general practice?
So I will talk a little bit about diabetes just because it makes up such a huge amount of my work, even though it is obviously something that we see everywhere around the world, and increasing rates to do with our less than ideal Western diet. But the difference that we have in the diabetes we see is that we see it much younger. So we will see adolescents and people in their 20s and 30s quite regularly being diagnosed with type 2 diabetes. And we see the complications of diabetes quite young as well. So it's not at all unheard of for people to be on dialysis from kidney disease related to diabetes in their 20s. And we also see heart disease at ages that is unusual in other populations. So we will see people in their 20s and 30s with ischemic heart disease. So all of those cardiometabolic endocrine issues just happen much earlier. And the reasons for that are very complicated. Obviously, there are fundamental social issues to do with poverty, which leads to issues with diet and exercise. There's the very high rate of smoking. There are clearly some genetic factors as well, and probably epigenetic and also definitely antenatal as well, especially around kidney disease. Low birth weight is one of the significant contributing factors to kidney disease. And so fundamentally, people who are born with a low birth weight actually have less functioning nephrons to start with. And so when their kidneys are impacted by further insults, there's just not as much reserve. So they're more prone to ending up with severe kidney disease. Some of the other things that we deal with are issues of nutrition. So malnutrition, both over and under nutrition, is a really significant issue right from pregnancy. Many of the pregnant women are either underweight or overweight, and smoking rates in pregnancy are around 50%. So the babies tend to either be macrosomic from maternal diabetes or underweight, low birth weight, more often low birth weight. And I think that probably is a lot to do with the smoking. And then that affects kids right through the lifespan, essentially. So starting at low birth weight, as I said, it affects their kidneys, but then they can become more prone to obesity once they hit adolescence. We see a lot of specific nutritional deficiencies, vitamin D and iron in particular. And we also see just really poorly controlled diabetes once they become diabetic as well. So sort of getting back to those adults with diabetes, so around 20 to 30% of our type 2 diabetics have a HbA1c over 10%, which for everyone who uses the other measurements is over 86 millimoles per litre. So that's a really high rate of poorly controlled diabetes. And then if we look at sort of some of those other conditions that are a bit less common elsewhere, rheumatic heart disease is probably one of the ones that people have heard about. And for those of you who haven't heard about rheumatic heart disease recently, because you work in an area where it doesn't exist, which is most of the developed world, rheumatic heart disease is essentially an autoimmune condition where strep infection causes an autoimmune reaction against the heart valves. It affects young people predominantly. It affects mostly the acute rheumatic fever element. Usually happens in kids between sort of 5 and 15. And it is basically unknown in most of the developed world. But it occurs in remote Aboriginal communities at rates that are really significant, some of the highest in the world. So, for instance, in some areas of the Northern Territory, up to 10% of the population in some communities are on secondary prophylaxis for rheumatic heart disease. When they did a screening study in Maningrida in the Northern Territory, at the end of their screening, 10% of the 5 to 20-year-olds were receiving secondary prophylaxis. The rates in WA are a little bit lower. So the Pilbara and the Kimberley, it's about 2% prevalence that we know of. And in the Northern Territory, across the whole Northern Territory, it's about 3% prevalence. Rheumatic heart disease is very much a sign of poverty. So although the traditional teaching that people might have heard of is that tonsillitis is the strep infection that causes rheumatic heart disease, or at least causes acute rheumatic fever, that's not really the experience that we have. We see rheumatic heart disease mainly being caused by impetigo. And we see impetigo because we have scabies. And also, in my experience, head lice. Head lice are huge. You might not think head lice are a serious problem, but for me, head lice are actually quite a big problem because that leads to scratching, which leads to skin breakage, which leads to strep infection, which leads to acute rheumatic fever. So that's one of the uncommon ones that we see. And I suppose scabies is another one that people wouldn't traditionally see a lot of in developed countries, but we see a lot of scabies. In terms of getting back to sort of rheumatic heart disease as well, I suppose the treatment for rheumatic heart disease makes it really difficult as well, because in order to, the way that we try and treat it is to prevent any more episodes of acute rheumatic fever. And to do that, people get put on prophylactic penicillin. So it's long-acting bicillin. It's a really quite painful injection. So it's 2.3 mils once you get over, I can't remember the exact cutoff, I think it's 20 kilos. It's not very much. So it's a 2.3 mil intramuscular injection every month from the time of diagnosis for 10 years. Or if you are young enough, it's from the time of diagnosis until you're 21. So we've got someone on our books who was diagnosed when they're 18 months old. So they're going to essentially get 20 years of monthly injections. There is research looking into giving it subcutaneously as an infusion, but that's not yet been started as a formal protocol outside of the research environment. But you can see why it's hard to get people to adhere to secondary prophylaxis. And oral prophylaxis doesn't really work in the population that we're working with for lots of different reasons. Lots of families don't have a working fridge, which is needed to store antibiotics. Medicines often get lost or destroyed. People are often moving a lot. And often people find it's really hard to remember to give the medicine to the kids. So that's why the needles are preferred, because they give better coverage, but it's really hard for the kids. A couple of other things we see that are a little bit unusual are trachoma. So again, in the developed world, trachoma is not really something that you would see. We do see trachoma. The public health people come out every year and screen the population, and if more than, I believe it's 10% have trachoma, then they give antibiotics to the whole community as prophylaxis. As I said before, we see scabies and impetigo, a lot of tinea infections as well. Really common to get tinea capitis. Sometimes we get tinea carrion. You might not think tinea is a big deal, but we see very severe tinea. So routine oral treatment, we don't really bother with topical treatments. They don't work. And then we see some very severe ear disease as well. So it might have been notable that of the visiting services we have, the only specialists that come out in community are a paediatrician and an ENT surgeon. And people might think, oh, that's a bit weird. Why would you need an ENT surgeon? That's a really subspecialist thing. Why don't you have like an endocrinologist? The reason we have an ENT surgeon is because we have chronic suppurative otitis media like you would not believe. So we just see very severe CSOM, lots and lots of runny ears. And as a consequence of that, we see a lot of hearing loss, which obviously has a lot of downstream effects, hearing loss affecting school attendance and school achievement, affecting people's interactions with the criminal justice system. So it's a really big deal for people to lose their hearing. And the kids usually have hearing issues at a very young age. And hearing aids can be quite challenging as well. There's sort of, I suppose, a bit of a thing where we tend to keep the hearing aids at the school so that the hearing aids don't get lost, and to try and make sure that the kids are using the hearing aids when they need them at school. And then with that chronic suppurative otitis media, then we do see cholesteatoma as well, even in kids. And we also see mastoiditis and osteomyelitis of the skull and other complications of locally invasive disease of ear infections. So you might not think that an ENT surgeon going out is a very useful service, but actually it's a really useful service for us to have an ENT surgeon. There's another condition that I'll just briefly touch on, which is FASD, or fetal alcohol spectrum disorder. We see quite a lot of that. We don't have the prevalence data in the population I work with, but in the Fitzroy Valley, which is a very similar population, the Lily-One study examined the children and found that 1 in 5 children met the criteria for FASD. And so 50% of the women had consumed alcohol during pregnancy. So we do see a lot of kids who have issues with development, language, all of those issues.
That's really interesting, Cara. Thank you. You mentioned diet a couple of times, and clearly diet very much linked to lots of the things you've talked about. What's the diet like for these communities? I mean, it sounds hard enough for you to get to work, let alone getting food. Do they grow and produce food locally? What's in the corner shop, I suppose.
Yeah, so horticulture, not much practiced. So there's no local growth, generally speaking, of fruit and vegetables and things like that. Every now and then someone will start up a veggie garden, but you don't see it much. If they do that, they have to water it from bore water, because the rain over the dry season is almost non-existent, or pretty much non-existent. So that's one of the reasons why it's quite difficult to have agriculture in the desert. The corner shop is very much affected by the remoteness. So the truck that comes in with food usually comes in once a week. In the wet season, that can be affected by the roads being closed, because the roads are often flooded. So whatever has come in previously will just have to stay in the shop. So fresh fruit and vegetables are potentially difficult to come by. Frozen veggies are definitely available, but there is much more of a reliance on ultra-processed and pre-packaged foods. There's a lot of soft drink, and there's a lot of very high sodium sort of tinned type foods. Quite a lot of the local people will go out hunting still. Actually, this is quite a funny story that I think people will appreciate from the last week. So I was having a chat to someone this week just gone, and they said that their pet cat was potentially back in their good books because it had brought in a live goanna. So the goanna had been promptly dispatched and put in the fridge for later consumption. The cat didn't get the goanna. So a lot of the people still hunt. And I also, and also hunting, so camels. There aren't many kangaroos. It's not really the right environment for kangaroos. But goanna, definitely. Bush turkey. And people also will go out and dig up tubers and things like that. But that makes up a relatively small proportion of the diet relative to the amount of Western food, which is the highly processed stuff. So which is your tinned food, your Coke, your pies, all of those sorts of things, which contributes to why we end up with the issues that we have. There's also a lot of tea. Tea is one of those white person foods that's been brought in and is now widely consumed. And with that comes a lot of milk, so cow's milk, and that really contributes to our iron deficiency problem, is excessive consumption of cow's milk.
Interesting. That wasn't something I was aware of. Is that something linked to the Aboriginal population itself, or is that something a bit more widespread?
No, cow's milk consumption is associated with iron deficiency in all people. It's more, I guess, relative to the amount of iron you're getting from other sources. So obviously, if you're not getting leafy greens in your diet, you're not getting it from vegetables. And for the kids, often red meat might not be a huge part of what they're eating. We do get a lot of worms, to be fair. I mean, like worms are a massive issue. So most of the iron deficiency is probably to do with worms, but excessive consumption of cow's milk definitely affects it. And it's due to absorption as well. So the calcium affects iron absorption.
Interesting. As someone who's on to his, I think, 6th cup of tea this morning, perhaps I shall better potter off to the GP myself to get my ferritin checked. You've mentioned a couple of research studies on prevalence and perhaps in some populations, better data sets than others. Is research within Aboriginal communities and Aboriginal medical services a big thing? Is it something you get involved with quite a lot?
Research is a really interesting topic. So historically, Aboriginal people have been a very highly researched group of people, just speaking very broadly. Because from a researcher point of view, areas with high prevalence of complex conditions and chronic conditions is obviously somewhere where you're wanting to do research. Got good data sets. But the problem has been in the past that the research has been, it's been of Aboriginal people, but it's not necessarily been for Aboriginal people, and it certainly hasn't been by Aboriginal people. And so now there has been a move to really strengthen the community engagement in research. And so in order for a research project to get off the ground now, it needs to go through a very, very rigorous ethics approval process. And that will usually involve some degree of co-design and community involvement, which is good from a cultural perspective and making sure that people are not being studied just for the sake of being studied, making sure that the research is locally applicable, that it'll be on things that can make a difference for the people. But it does mean as a potential researcher that it's a bit off-putting. So I'm listed as an investigator on a few research projects, but I would never dream to try and start a research project myself to try and get through all of that sort of paperwork. And it's particularly hard, I think, for clinician researchers who are not backed by, say, large organisations with a lot of resources to be able to spend enough time away from your clinical work to get through all of those things and start a research project. And certainly in my head, I've got a lot of interesting data sets that I know that I could pull and would be worth looking at, but it's a little bit difficult to get that off the ground.
Yeah, absolutely. So admin never leaves us anywhere we work, so by the sounds of it. Are there any, you must have seen some fascinating cases and worked with some, really interesting people. Are there any particular cases that stick with you to this day?
Yeah, there are a few. I think rather than going into specifics, because some of the people are still alive, and some of them are not, I have a number of rheumatic heart disease cases that really stick with me. Mostly, and this again is one of those things where, because most people wouldn't see rheumatic heart disease, they wouldn't know much about it, but in terms of how rheumatic heart disease affects you, the consequences of rheumatic heart disease in terms of things that are likely to kill a person or likely to cause serious long-term problems are actually more neurological. So strokes, or in one case, a cardiac arrest. So I've seen a few patients, some very young, who have had serious neurological sequelae from their rheumatic heart disease. And some of those people have survived with severe neurological impairment, and some of those people survived for a while but ended up passing. But the age of those people really kind of gets to you, because rheumatic heart disease is a preventable condition, and the consequences are huge. And those people have ended up essentially having what you would only expect to happen in old people, like strokes, but really, really young.
Always more difficult and more triggering, aren't they, those cases that happen in your own decade, or I've certainly found that people I've seen
or younger
really, really hard to deal with, aren't they? You mentioned early on about nerves and anxieties around taking on a job, and I think imposter syndrome is something we've all dealt with at some point in our careers, and certainly something that I'm feeling quite strongly right now. Is that something, how have you dealt with that through your career in this role? Is it something that still affects you day to day?
Yes, intermittently. So it really just depends on my mood of the day, and it depends a little bit on individual cases. I'll see something and I'll go, oh, that's a learning opportunity. But before it's a learning opportunity, it might cause anxiety. I think some of the different ways that I manage anxiety around the work is around trying to remain up to date and well educated. So trying to keep myself as skilled as I can in those sorts of skills which are infrequently used but might be important. And then some of it is around essentially just going through that logical process in my head of, well, if not me, who? the answer would be probably no one. So if I feel anxious about going out to a community and I feel that I don't have the right skills to do the job, the reality is that it's very hard to get people out there. And if I don't go out, probably I won't be able to get anyone to go out. So something is better than nothing. And then it's also good to debrief as well. And so I debrief a lot with colleagues and with my partner and people around me. Often if I debrief with colleagues who are medical, they usually think I'm crazy, generally. Like, it's like, what are you doing going out there? I could never do that kind of thing. So they're not so helpful for debriefing because they just reinforce your fears. But it is good to be able to let off steam with other people working in the same area who understand the day-to-day issues. And then we're able to kind of to ventilate a bit. And then at the end of that, you also need to look back on each time an incident happens and go, well, how can we learn from this? What can we do at an organizational level? What can we do at a professional level that's going to try and make things different next time if we have a similar thing? And so that's, for me, really important, is that continuous quality improvement. And every time there's a potential problem, making it a learning opportunity.
Excellent. Sounds like very sensible advice for everyone, people working everywhere, I think. So you mentioned early on around, I think it was second epiphany, that you had the dual job of trying to pass your exams and sort out your social/dating life. And obviously met your husband, and now you've got a son. What was that like, navigating being pregnant, becoming a mother, while working in a rural job? Very different, I suspect, to commuting down the road in Perth.
Yes, it was quite different, actually. So when I first got pregnant, I thought that I was going to be working at the job I was at, which was 2 weeks on, 2 weeks off, going through remote communities until maybe 34 weeks. But my obstetrician had different opinions. So she said that 20 weeks was the limit, and then you had to come back to Perth. So I got grounded. So I had to hand in my resignation a bit sooner than I was planning to, because that was what I did, was I handed in my resignation. I didn't think I was going to be able to go back. So I'd been doing the 2 week on, 2 week off job for 3 years at that point. And I was like, yep, once I've had this baby, I'm not going to be going back and working remote. So handed in my resignation, came back to Perth. Had the baby, a bit complicated obstetrically, but that was okay. Went back to work at my metro practice 8 weeks after. But I did sort of notice they hadn't managed to replace me in the time that I'd been away. So when Alex was 4 months old, or just before, I reached back out to the CEO and said, I noticed you haven't been able to replace me. And this also sort of fits into that time of COVID, which this won't mean much to the rest of the world. The rest of the world, COVID was horrendous. In WA, COVID was not horrendous. We actually had no COVID until the borders opened back up. So during this time in 2021, actually, there was no COVID in WA, but you also couldn't get doctors in because the borders were shut. It was almost like the Iron Curtain, just about. You literally couldn't get people into WA. So the doctor that had replaced me was based out of the eastern states, and so was unable to come to WA with the closed borders. So I reached back out to the CEO. I was like, oh, would you like me to come back? And he was very keen for me to come back. They were very short-staffed. So I was like, okay, well, I can give you 1 week in 4. I had a metro practice at the time. I was working in 2 days a week. And I said, 1 week in 4, I reckon I can do that. And so the very first time I went back, I just did the remote trip. So I didn't go to Jigalong for 2 days. I just did the 3 outer communities. And I took the baby and the husband. And the pilot was not impressed. I had 60 kilos of luggage to get into a barren 6-seater. Who may have made some comment about how he was going to strap it on the roof rack. Anyway, but we managed to get ourselves and the baby in a car seat into the plane, and we managed to get to the remote communities. And I managed to do 3 days, so that was fine. And then I was like, okay, well, I'm not taking the husband and the baby next time, so I'm on my own from now. So it was a bit of a challenge. I don't think that everyone would be able to do it, but I am particularly bloody-minded and stubborn. And so I was able to make it work. So I would leave on my usual day, which was my Sunday, go out to the community. I had with me my usual luggage plus a breast pump and a freezer. I had a little portable freezer on a trolley, one of those like camping ones with a lithium battery. My pilot thought not a lot of that lithium battery either. I was not allowed to run the freezer on the plane, and I had to have the freezer where I could see it, and he was instructing me how to throw the freezer out the door of the plane after jimmying it open if it caught a light, because he thought it was a cheap Chinese knockoff. Anyway, so I had my little freezer and my breast pump, and I'd go out, and so I would work and I would pump and I would freeze the milk, and then I would do my 5 days. And then I'd get to my last community, Kunawarigi. I'd set the freezer to -20, and then I would like deep freeze my milk, and then it would usually stay mostly frozen all the way back to Newman. So that's an hour and 45-minute flight back to Newman. And then I'd go to Newman Airport, and you have to understand Newman Airport. Like Newman Airport, it's full. I'd be one of like 5 women in the whole airport. It's full of blokes in bright orange high-vis gear. So I'd go there, I'd plug my freezer into the PowerPoint. That I found a little PowerPoint next to the check-in counter. I'd plug my freezer in to give it a bit of final juice to really get it cold before I'd send it to Perth. And I'd sit there on the floor and pump, and then put the last bit of milk into the freezer. And then I'd tape the freezer up with gaffer tape. And then I would take it over and put it in my checked luggage. I'd get on the plane and come back to Perth. And in the meantime, like on the days, I would like every night I would video conference with home. Alex at that point, my baby, obviously had no idea. Like I'm not even sure if he could see my face on the phone or whatever, but he didn't seem to mind. And then I kept breastfeeding until he was 2. So I kept it up for a while. I stopped taking the freezer when he was about 18 months. I discovered that I didn't have to pump, but I just sort of made it work. He's used to me being away. Now his language is a bit better. He says he misses me. But overall, it's one of those things where if the genders were the other way around, no one would think much of it. But it is a bit of a challenge being away as a working mum. And then when I was only doing 1 week in 4, I had a practice still in Perth. I was doing 2 days a week working at a practice in Perth. But then our senior medical officer was taken by the local country health service. And so I was asked to take on the senior medical officer role, and I couldn't do both at the same time. So at that point, I gave up the Perth practice and just kept going out and doing the clinical work 1 week in 4. And then I do the rest of my job remotely, all my management, admin, and so forth.
Brilliant. Well, certainly sounds challenging, but sounds like very much making it work. And I'm sure Alex likes having you back when you're back home. You mentioned they couldn't replace you when you initially left. I suppose that's always nice to be irreplaceable. But perhaps that represents more of I know there's some difficulties in recruitment in parts of Australia, and it certainly sounds like with some of the distances and remote aspects and challenges that must be tricky. How are the Aboriginal medical services like PAMS and others able to recruit, and how are they able to continue to provide services in amongst all those challenges?
Yeah, so recruitment is a huge issue, and I think it's a huge issue across the world. I certainly see there seems to be a shortage of doctors everywhere. Every nation seems to be crying out for doctors. So it's not a unique problem for us, but Aboriginal medical services in remote areas at least have some additional barriers. Firstly is that some of them are in places where it's just hard to get someone to want to go and work there. Very remote places, some of them, for instance, in the desert, the climate is not entirely friendly to everyone. Some people love the climate, but some people might find it a bit hot and oppressive in the wet season. It's a particular kind of work. It can be quite emotionally stressful. So those things all play into it. And because there's a universal job shortage, then recruiting compared to, say, recruiting in a metro practice, it's a little bit more difficult. And then there's also the funding aspect, particularly for the remote clinics, is an issue because those sorts of jobs going out to very remote areas, the kinds of doctors who often will want to do that or have those skills can be offered significantly more pay to work for the local country health service hospital. So we're not really able to compete with that. And so we have been moving now to looking at recruiting from overseas as well. So we've actually got a recruitment trip coming up really soon, which I'm looking forward to, coming to the UK and to Ireland, talking to doctors, seeing if they're interested in coming out and working in the Aboriginal medical sector. And it also is one of those things where training and things like that comes in. So we are a training site. We haven't had any registrars so far, but we're also, you know, hopeful that at some point we can get registrars on board and allow people to learn through their training, which hopefully then means they'll be keen to continue working in the sector going forward.
Excellent. So I suspect this will come out after your trip, but I'm sure there'll be lots of people listening in for more details who you've met in Ireland and the UK. We've touched on various challenges of your work. What are some of the real wins you've seen? So either sort of individual wins or kind of organizational wins. You know, what are some of the real successes of PAMS and some of the other Aboriginal medical communities in remote Australia?
So I had a bit of a think about this one before we started. And overall, I think the biggest success is that we just keep going, keep persisting. We lose staff, we deal with floods, we deal with road closures, equipment failures, seemingly insoluble logistical issues, and day in, day out, we continue to provide a service. That's probably the biggest win. There are some other little personal wins. I think now the communities I work in, I have a relationship with those communities. I haven't had anyone ask to see the doctor who retired 9 years ago for ages, like, you know, ages and ages. It's been months at least since anyone's asked for him, possibly because he was actually well known in the community and they know now that he's passed away. But prior to that, I did get occasionally asked for where he's gone. But overall now people seem to know me. They recognize me, they want to see me. And so that's a really big win, is that people say that I'm their doctor. That's taken a long time to build that relationship, but that is one of the most important things about it. And so when I build that relationship, I can have little wins. I can get someone to give up drinking Coke, give up smoking. In fact, that's my biggest ever success story, is a very senior elder in one of the communities. And this is going back when I hadn't been working for PAMS for very long. And he had really not great lungs and he needed to quit smoking. And I'm very blunt. That's how I am. It's my nature. I'm very blunt. So I was pretty blunt with him. And I said, if you don't give up the smokes, you're going to be dead in 12 months. And I don't think that's a conversation that's uncommon amongst GPs. I think the give up smoking or else is quite a common discussion people have. But a day or two later, I got a phone call from him and he was really upset. He was like, you have pointed the bone at me and this is a really big deal. And, you know, the implication being that if he dropped dead, it would somehow be my responsibility for having told him that. But it clearly had the perceived or the intended effect, because he quit smoking. And he's lived a lot longer than 12 months. And so that was a huge success story for me, because you don't have many success stories with getting people to get off the smokes. And the fact that he listened to me, and even though he wasn't very happy with the manner in which I gave the advice, he took it on board and got off the smokes, then, you know, and that's contributed to increasing his lifespan and hopefully also increasing his quality of life. So that was for me, that was a big win.
Brilliant. Well, I don't think there's many healthcare professionals out there who've got a story like that. I don't think anyone has ever followed my advice, however graphic or direct or blunt, regarding stop smoking. So I think that definitely is a real win. And now, talk to us a little bit about the history of PAMS and you know, about yourself and what brought you to this role. What do you see for the future for PAMS? Is there anything, you know, particular on horizon, or yourself? Any kind of epiphanies coming up, do you think, that might redirect your career or send you elsewhere?
I'm not sure where PAMS is going. I suspect it will continue to get bigger. As an organisation, we've rapidly expanded into a lot of things that are not primary care. So our programs team has become significantly bigger. For me personally, every now and then I think about going and doing public health training, but I didn't get a chance to talk about syphilis in the things that we deal with. But syphilis is absolutely huge and a significant thorn in my side, and public health training, unfortunately, just means more syphilis. And I feel like I've had enough of that, to be honest. I've been dealing with that for a while. So I do know that I'm really interested in dealing with things at a population level, but where that will lead me, I'm really not sure. So for the moment, I'm sort of still trying to keep on providing the service that I can, recruiting so that we're not quite so short-staffed and not living on locums. And then maybe in the future, I'll try and see if there's something that involves a more population-based approach, because I feel like that's where the most effect can be had, is working with the whole of population.
Perhaps it's time to finally retrain as that water engineer.
Yeah, that would be really useful. Especially recently, I couldn't go to a community because the water wasn't working. So if I was a water engineer as well, I'd go, that's fine, don't cancel my trip. I'll come and I'll fix your water problems too.
Exactly. So there's the first moral of the story. And I suspect, I mean, the second moral of the story from my point of view is perhaps, record a podcast with your future boss to find out, firstly, all about the job you're going into and then all about her. So, I mean, it's been absolutely fascinating, really, like I said, I was really looking forward to chatting and recording this. And it's been way more interesting and sort of wide ranging than I thought. So thank you so much for coming on the podcast.
Not a problem at all. Be my pleasure. I look forward to working with you next year.
Fantastic. And is there anything else you want to leave the listener with, Cara?
Well, you had on the set questions a final inspiring story why you love your job or whatever, but this one isn't inspiring, but I think it's the kind of thing that can only happen in my job. So during a consult last week, the patient was going out camel shooting and he promised me camel backstrap for dinner and he didn't come through. So I think I still need to go back to work because I'm owed some camel backstrap.
Excellent. That's one of the better podcast endings I've heard. Fantastic. Well, thanks again. Look forward to chatting soon, and I'm sure find some really fascinating things to come in the rest of your career. Thanks, Cara.
Thank you.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website where you can find more engaging content on extreme medicine webinars and indeed a collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.